Hello, I'm Uchechi Okeke from Oculus Prime Eye Clinic, and today I'll be talking about esotropia. Esotropia can be defined as a manifest inward deviation of one or both eyes, and it can occur at any distance or with any task. Esotropia can be divided into three. We have the primary esotropia, secondary esotropia, consecutive esotropia, and residual esotropia. Now, for the residual esotropia, it has to do with someone that has had esotropia and then had a surgery, but even after the surgery, there still remains. So it means that even after the surgery, the patient was still esotropic. That's called residual esotropia. Then we have the consecutive. Consecutive means when someone was exo, so the patient had an outward deviation, had a surgery, and now became esotropic. That's called consecutive. Then we have the secondary. Secondary, as the name suggests, this patient had this esotropia as a result of a condition. So probably the patient had loss of vision, visual acuity, usually in childhood, right? Then we also have the primary. So it's the primary that has its sub classifications. There might be other sub classification of secondary, but I won't talk about that. I'm going to talk about the primary sub classifications. Now, primary sub classification of esotropia, I won't go in depth. I will just let you know so that you have an idea of what to diagnose or how to narrow down your diagnosis, when someone walks in with esotropia and it's a primary condition. Now, primary esotropia can be divided into constant or intermittent. So, primary esotropia, first of all, is esotropia that is idiopathic, right? It didn't result from a condition, right? Now, this primary esotropia, so the first thing you think about is it constant or is it intermittent? Now, constant esotropia has to deal with it occurs all the time. So at every point in time, this patient is esotropic. Whether you're looking at far, whether you're looking at near, whether you're, doing any task, the patient has this inward deviation of the eye. That is constant. Then we have intermittent. Intermittent means that at a particular time, this patient is esotropic, and at another time, this patient is phobic or ortho. So it means that at a particular time, this patient has tropia, but at a particular time, the patient doesn't. It might be at near, the patient is tropic, at far, phobic, or at far, tropic, at near, phobic, or sometimes of the days or, period of time, patient is tropic, another time, the patient is not tropic, right? So we'll go into details. Now, for constant esotropia, you then ask, you now want to know if this is accommodative or non-accommodative. Accommodative meaning that this patient is hyperopic. Let me just summarize it. So what I mean is accommodative meaning this patient has a refractive error, and most of the time, because it's esotropia, it is hyperopia. So accommodative, is this patient accommodative? Is the refractive condition related to this esotropia? That is accommodative. And non-accommodative is the refractive condition not related, right, to this esotropia. So the patient might have minimal refractive condition or refractive condition, but it's not related. It doesn't affect esotropic condition. So whether it is dealt with or not, the esotropia is not affected. That is non-accommodative esotropia. Now, for accommodative esotropia, we can now narrow it down. What are the types of accommodative esotropia? So we start thinking in our heads, right? What are the types? So I'll first of all say for the accommodative esotropia, we have convergence excess esotropia. Like I said, I won't go into details. In my subsequent videos, I'm going to be digesting each of these various types of esotropia one at a time. But for this video, I'm just going to be mentioning them and, make a summary of what you expect. So for convergence excess esotropia, as the name suggests, high ACA ratio, this patient will definitely have high ACA ratio because the patient is excessively converging, right? And because we know about the near triad, convergence, accommodation, and meiosis, right? So once the patient is converging excessively, accommodation is also being exerted, and of course, meiosis. So as a result of high ACVA ratio, this patient is tropic at near, because remember that accommodation is exerted during near work. So this patient is tropic at near, right? As a result of excessive convergence, as a result of high ACA ratio. And that will tell you that when the patient is at far, this patient is phoric because accommodation is not exerted at far. All right. This condition has a differentials with near esotropia. I'm going to talk about that. But just know that high ACA ratio, is associated with convergence excess esotropia. Now, we also have fully accommodative esotropia. That's another type of accommodative esotropia, fully accommodative esotropia. From the name, you already know, it means that this patient is fully accommodating. So the patient has hyperopia, and this hyperopia is dependent on this esotropia. So the hyperopia is dependent on the esotropia. So what I mean is, when you correct this hyperopia, the esotropia disappears. Do you understand? That's the sweet part about fully accommodative esotropia. When the patient wears his or her glasses on and, relaxes accommodation, as you know, plus lenses does that, right? So when the patient wears his or her glasses on, this esotropia relaxes at every distance. So both at far and at near, the patient becomes what? Ortho. So the patient doesn't have a manifest deviation anymore. The patient becomes phoric, or ortho, what have you, right? But when the patient takes out these glasses, so these are patients that the parents might say, why is it that my child, if he takes off the glasses, the eyes just goes back to being deviated, inward deviation? Well, it's because this esotropia, you treat something by the cause, right? So this esotropia was caused by the hyperopia. And dealing with hyperopia, like we all know, hyperopia is a refractive condition that has to do with light rays. And how do you deal with that? You deal with that using lenses, because it's lenses that can refract these light rays and help you see clearly at the back of your eyes. So when this hyperopia is dealt with, the esotropia disappears because the esotropia is dependent on the hyperopia. I don't know if I'm trying to make sense here. So that's basically for fully accommodative esotropia. And it's really an interesting condition. Probably when I'm making a video, I might show a video of what it looks like. But, the patient wears glasses, esotropia, no deviation. Takes out the glasses, deviation comes back, right? So for patients like this, obviously, you have to make sure that you advise properly and let the parents know that this child has to wear the glasses constantly, all the time. Now, that's that for intermittent. That's for accommodative, intermittent esotropia. Now let's go to non-accommodative intermittent esotropia. The first one I'll talk about is near esotropia. Near esotropia has to do with, like the name suggests, the patient is tropic at near, but at far, the patient is phoric. And this is a differentials with convergence excess esotropia because they both occur at near. But then we know that convergence excess esotropia results from high ACA ratio, right? Now, when it comes to near esotropia, ACA ratio is normal or low. Also, when it comes to near esotropia, the refractive condition usually is like not significant, let me put it that way. Or in other words, you can actually say it's not related to, that's why it's called non-accommodative, right? It's not related to the refractive condition. So it's not connected to high AC ratio, it's not connected to the refractive condition, So that's near esotropia. Phoric at far, tropic at near. Far, distance, esotropia, the same thing. At far, this patient is isotropic. At near, patient is not isotropic. Patient is phoric at near and tropic at far. Then we also have a cyclic esotropia. Cyclic, like just as the name suggests, to in a cycle. So in a period of time, this patient is tropic. Another period of time, this patient is phoric. So the patient is not tropic all the time. And this is why this classification is the classification of non-accommodative intermittent esotropia. The near, the distance, and the cyclic. Now, that's for intermittent esotropia. Let's move over to constant esotropia. So constant esotropia can be divided into accommodative and non-accommodative. So always have in your head, constant or intermittent. Constant, is it accommodative or non-accommodative? Now, for the constant esotropia, the non-accommodative types of constant esotropia will be the infantile esotropia. Usually infantile esotropia occurs in children less than 1 year old. I will talk more in details about that, but just know that infantile esotropia is a type of non-accommodative constant esotropia. Occurs all the time. Just that there's a threat to it. These patients are usually not amblyopic because their eyes are alternating. So most times they have alternating esotropia, but it is constant. I don't know if don't know if you're understanding me, but don't worry, you understand it in subsequent videos. Then we also have acquired esotropia, right? And then we have other rare types like nystagmus block. I'll move over to accommodative constant esotropia. We have one type, and that is the partially accommodative esotropia, or you can call it the esotropia with an accommodative effect. So it's either called partially accommodative esotropia or esotropia with an accommodative effect. And what's this type of esotropia? Simply put, it's the type of esotropia by which you wear your glasses, esotropia is reduced, but it's not totally taken away, right? So this kind of esotropia is dependent on the patient's refractive condition, but not fully. So that's the difference between this and the fully accommodative esotropia. Fully accommodative takes away, the glasses takes away all esotropia, did manifest deviation. But in partially accommodative, it takes away part of it. So what happens is this patient wears the glasses, the deviation is reduced. So the deviation is reduced, but the esotropia will still remain with the glasses on. You just notice that the angle is reduced. So this patient most of the time will also have subsequent methods to control the remaining esotropia. I hope I have explained it the best way that you can understand. If you have any questions, you can pop some questions to me via my email address, or you can also go to